Good afternoon on a Saturday. Welcome to Beyond Telehealth, and I'm Dr. Lisa Finkelstein, and we are going to talk about remote patient monitoring and telemedicine is medicine. I'm here today with two wonderful nurses, Ashlee and Jackie, and this is part 2 of remote patient monitoring with cardiac heart failure patients. So Ashlee and Jackie are going to introduce yourself first. So Jackie, you go first.
Hi, everybody. Like Dr. Finkelstein said, my name is Jackie. I'm an advanced illness management nurse with Mainline Health Home Care and Hospice. I have a certification in cardiac vascular nursing, and I'm also a certified health coach.
Okay.
Hi, everyone. Dr. Finkelstein, thank you so much for having us here. We're really excited to talk about everything telehealth and remote patient monitoring that we do. Like she said, my name is Ashlee Whelan. I'm a registered nurse at Mainline Health Home Care and Hospice, certified as a health coach and board certified in cardiovascular care as well.
So Ashlee, tell us what remote patient monitoring platform you guys use and where you practice.
So the platform we use is through Medtronic. It is currently, we're transitioning to all app-based platforms. So we're using, with technology, we're keeping up with it using applications through tablets, eventually maybe even through smartphones. And we're within the home care division of a large health system.
Okay, so Jackie, let's go back to you and let's go to the beginning. And we talked about this with Jen Fox, but what is RPM, remote patient monitoring? How does it work?
So remote patient monitoring starts with the patient in the home. We send telemonitor equipment to their homes, and that telemonitor equipment is personalized for their disease process. It includes a modem, a scale, a blood pressure cuff, and a pulse oximeter. And that equipment is placed in their home, and we ask them to do a health check every day. First thing in the morning, empty belly, empty bladder. And then what that does is it does what we call a health check, which asks the patient a bunch of questions regarding their symptoms. It's yes and no questions, very easy to follow. It also provides some education, and then it takes the patient's vital signs. All of that data is sent to us through a secure website where we can get the information in real time.
Okay, so Jackie, now take us to how does that work then with, well, let's go back to how does the patient enter into this program of RPM?
So our patients are on home care. And so we have nurses that visit them in their homes. The home care referrals come from doctors' offices. They come from hospitals. And that's who orders home care in general. The nurse that goes in the home will assess the home. They'll take a look at the patient's history and determine if they're appropriate for telemonitoring. Patients such as those with heart failure, COPD, cardiac surgery patients benefit from this. Also, anybody dealing with blood pressure concerns that are still being titrated with their medications. These are all the types of patients where we get the referrals from. And again, the referrals come from the nurse in the home, as well as our referral source will suggest telemonitoring.
Okay, Ashlee, so do you want to add anything about that process?
No, it's pretty much, she covered it where the referrals come from. And like Jen said, Jen's one of the nurse practitioners for a local heart group that she makes referrals all the time. And usually it's after the patient's in the hospital, and she said, sends them to us, and we all just kind of work together.
So this is a theme that's starting to really take hold across the country called aging in the home, right? And so the patients, Ashlee, let us know about the type of patients that you guys deal with.
So we deal with patients primarily after a hospitalization, but they're elderly patients, not just elderly patients, anywhere from 50, 60, 70s, 80s. We have patients that are 100 years old on the monitor, with chronic illnesses primarily. Like Jackie mentioned, patients that were titrating medications for blood pressure. And then do you want me to talk about COVID now, or should we wait, or kind of just focus more on?
Well, you could no COVID because what happened with COVID? We can talk about that. You said that it exponentially increased your load, and how?
Absolutely. So we were even starting to build our census up not long before COVID started, but right when COVID happened around last March, when everyone was going home and remote, I remember our manager came over to us and saying, all right, what can we do? How can we help our patients coming home with COVID? How can we help our health system, the doctors, everyone? And got on the phone with our rep from Medtronic, and they were already working on something. They were on it, and they had a disease program set up for us. And we just all came together and got monitors out there to help monitor these patients. I mean, easily over 100 right off the bat, were ordered, and then we were monitoring them as soon as they came home from the hospital.
Specifically, though, tell us, what was that program that was implemented? What were the devices? How did it work?
So if they had a history of heart failure, of course, we'd send out a scale to manage their daily weights as well. But primarily, it was the modem for symptom management. It was a respiratory disease, infectious disease design or disease program that was set up on the monitor. So they would answer symptom questions. Are they short of breath today? Things like that. And do they feel feverish or have chills? So we would get all that data. They would also get a pulse oximeter and a blood pressure cuff. And we knew the pulse oxes were huge to monitor that very closely, get trends. So we put together a protocol, monitor them 4 times a day for the first week. We had nurses always watching the monitor, collecting data. We would also monitor temperature twice a day. We would get those readings just to keep a really close eye on patients coming home with COVID that, were scared and just needed information, needed monitoring. Some we were able to intervene with, medication changes that happened in the hospital. We were able to reach out to their physicians, get medications back on board. Other times it's, if you have to send patients back to the hospital, they were so scared to go. That was a huge thing that happened. Patients didn't want to go to the hospital and they needed to. So we had a lot of those conversations as well. So that's kind of how that happened.
So Jackie, are you guys in these situations? You are the front line, right? You're interacting with these patients. How does that work?
Well, like Ashlee said, for the first week that they're home, we have them monitoring their vital signs 4 times a day, because we found that was really a critical time where they're no longer in the hospital, hooked up to machines with a nurse by their side. They're at home and they're alone, and so their connection is to us. And if they're having any trouble, usually in that first week or so is when it's going to happen. And so we were confident that we had the tools in place to help respond to those situations. And a lot of them were symptoms accompanied by vital signs that were out of whack. So maybe somebody's pulse ox would drop and they're having more shortness of breath. And, we then would take that information. Of course, we contact the patient, and that's really that first line of defense. We are communicating with the patient and their family on a daily basis, and making sure that, things are status quo. If they're not, we are, picking up the phone and calling the appropriate physician, and finding out what the next steps are. We've found so many out of the ordinary things that happen after patients come home recovering from COVID. For example, blood pressures that are through the roof and blood pressures that are very low, heart rates that are through the roof and heart rates that are very low. It really has wreaked havoc on patients' what their normal is. And we've had a few good catches as far as patients who came home from the hospital recovering from COVID-19, and we've had to send them back due to low pulse oxes and shortness of breath, and maybe change in mental status. And it turns out they had a couple PEs, and that's happened more than once. So the tool is really life-saving.
And what's the feedback about that? Have you spoken to patients, spoken to providers, spoken to ERs? Do they say this is unbelievable? What do they say?
Well, I think we hear mostly from the families and the patient, and we really they're grateful to have the connection with us. They're grateful to have that eye on them while they are scared and recovering. And sometimes we don't hear from the referral sources after the fact, but the fact that we keep getting the referrals is good for us. We feel like they see the value in it now.
So Ashlee, a lot of the success of this is based on technology, what we're doing like right now. What happens when there's difficulty with the technology from the home? How do you guys troubleshoot that in the field?
We have a few different options. Sometimes, we usually start with calling the patient, see what trouble that they're having. We might need to troubleshoot the equipment. Depending on the issue, we can do it ourselves with the patient or a caregiver. Other times we'll call the company Medtronic and we'll do a three-way call, work with the family to troubleshoot the equipment. Most times we can do things over the phone, but other times you need to physically go out and help the patient, whether that's us or our wonderful nurses and clinicians that are in the home there helping them. So we have a few different options and resources.
I want to go back again. I have another question. So Ashlee, how long has this program been up and running with Medtronic? How many pre-COVID years back?
Right, so a long time. So if you look back around 2007, before Jackie and I were involved, it was Nurse Martha, Mary Beth. They started this program with 30 monitors. And Martha worked the weekend. She was covering it all, doing it herself. And it just was for heart failure patients and managed it that way. And then over time, they saw the benefit. They added like COPD management to it. From there, it developed into this idea with chronic illnesses. There's so much more involved with care coordination, transitions in care, social determinants of health. We look at all those barriers, and then there was this advanced illness management team developed from that, where we use that monitor as a tool to help monitor and engage patients in their care and help them learn how to help care for themselves as well. So you initially started 2007, then Jackie and I joined in about 6 years ago. So it's been going on for a while.
Nurse Martha and the team in the beginning were very forward thinking.
Yes.
We're not going to go into this today, but reimbursement of RPM is for sure a thing now. And so way back when it started, there was not reimbursement, but now there is reimbursement. I'm going to just look real quick at these comments. Hold on, guys. All right, these are just, never mind. These are just saying hi. Okay. And so let's talk about the why. Ashlee, you said to me, I love what I do. Tell us why. Why do you do RPM? Yeah.
I love that it allows us to monitor so many patients at any given time, and we are very connected with our patients. Like, I have the best of both worlds, where I know the patients, I know the families, and I know them over a long period of time. The joy I find from it is where I can provide reassurance and peace for a patient or caregiver when they're worried about, their blood pressure, or they call me. I can provide that education, what to look for. And also those success stories that happen. I think of the one patient a few years back who, he didn't need monitoring. He was fine. He didn't need it. He had a heart failure. It was in and out of the hospital a little bit. And one of the times he came back to home care, we're like, all right, let's try the monitor again. And he just didn't want it. And within 7 days, he was back in the hospital. So we're like, all right, now we need to do this. We need to try something different. And in addition to our monitoring, we also incorporated a flexible IV diuretic protocol in the home. So we definitely needed to have the monitor in there. And he agreed to it, though a little reluctant. But once I got him on the phone, he was fine. I was wondering what the barrier was. Speaking with him and his wife, especially those first 3 weeks when he was so fragile, I was back and forth with the physician as well, which was another amazing piece of that. The physician was instantly, I would get responses from how to change his diuretics. We, maxed out on his oral diuretics and initiated IV diuretics. Eventually, we transitioned him to our palliative program, and it was just such a successful situation. Like I thought, I check on him every now and then, and he's doing great. Like he's still doing well, and it was a real successful story, and just to have that turnaround. Like I love it, and I love knowing these patients and their families, and just helping educate them, and just being another resource.
And that's going way back. My dad was a urologist, and he was in his 80s. He passed away last year. But the old-fashioned model of medicine was getting to know your patients and getting to know the families and the neighborhoods and where they lived. And so even though this seems to be scary to a lot of patients, it's what I call the virtual house call.
Mm-hmm.
And where the patients and the families appreciate being able to be at home, and they don't have to go to an office or the hospital where it's scary. And so ultimately, when they get over that fear of the technology part of it, then they just love it.
Right.
Yeah,
right.
and appreciate. So Jackie, tell us about the team, the village that happens behind the scenes to make this work.
Right, because it's not just Ashlee and I. We are a team of 10 nurses. We're part of a team of 10 nurses and our and support staff, and we're behind the monitor. But it goes beyond that. It starts with our referral source. We can't put the monitor in the home unless we have a home care referral, and so we value our relationships with our hospitals and our neighboring physicians as well. People that work with us include field nurses. You've heard me refer to them a few minutes ago, and these are our home care nurses. These are our troops on the ground that visit our patients week to week. There are therapists as well, physical therapists, occupational therapists, speech therapists. We have wound specialists. We have diabetic educators. We have social workers. So it takes a village to manage our patients at home. As you guys are probably aware, our patients come home sicker. They're in the hospital for less amount of time. We get them home. We're still titrating medications at home. We're still stabilizing them while transitioning them from the hospital setting to the home setting. And that takes a team. And we're just part of that team. And I think a very valuable resource to the team as well.
Do the people that you mentioned, because I've spoken to a lot of the people on those types of teams, pre-COVID and post and in COVID, where telemedicine was not being reimbursed pre-COVID for speech, OT, and PT. Do the people on that team, are they able to do some of these things utilizing telemedicine rather than going into the home now with COVID?
Well, currently, our department is the only ones using this equipment. However, our agency did have plans for, if needed, for those therapy services to be conducted, and even nursing services to be conducted over the telephone, if COVID really restricted travel. But we didn't end up using that. They make all their visits in person right now.
Okay. Let me just look at some of my questions here. So, Ashlee, do you think that RPM saves the healthcare system money?
Absolutely. I mean, I know we prevent hospitalizations with our level of coordination. I know we help minimize the redundancy and overutilization of other services. There are, I think we save a lot with, oh gosh, I'm just drawing a blank here, with the hospitalizations.
Transport.
And the transport and physician appointments and just all that goes into that helps improve care for the patient and minimize the hospitalizations and everything along with that.
Readmission rates that's a big thing for the hospitals. You know, they get dinged from CMS Medicare for patients that bounce back early, and so the success of what you guys are doing is preventing that from happening.
Exactly. The little changes that we initiate, whether it be a medication change or arranging a physician appointment when there's a problem on the horizon, those are the things that we initiate, which prevent hospitalizations. It prevents those people from getting to the point where they need to go to the emergency room.
Right. And Jen Fox, you know, I can tell she's an Energizer bunny. She's the NP. She says, you know, it takes me like a minute to answer an email, change the medication.
Right.
That whole process could take hours, you know, or days.
Absolutely.
Yeah. Okay. So Ashlee, do you think that RPM is here to stay and that it's sustainable?
I do. I know, you know, we were growing, you know, slowly as it was anyway, and I was starting to see the improvement there with telemedicine and in remote patient monitoring. But when COVID happened, it ripped off that Band-Aid for telehealth and telemedicine, and it just really put everything on the forefront. And, you know, it forced people who are a little resistant to that technology to just go ahead and dive in. And I think everyone really sees the benefit, how much, you know, I even look back to, and even forward, like how that affects our patients if COVID wasn't around, the patients that can't always get out for all the doctor's appointments, all the specialists, you know, being able to do a telemedicine visit and send over their vital signs and all that information so they have all the data that they need. I can just see how beneficial it is. And I can only expect it to grow more. I mean, I've experienced how much it's grown so far. So I can't imagine it slowing down. And we're keeping up with technology. This generation that we're going into with the chronic illnesses, they like technology. They like instant responses, instant answers. You know, I like scheduling everything online. I don't like to pick up a phone and call. I just like to get it all done. And, you know, it's where the technology is going. So I do.
Everything is being flipped on its head, and the new model is bringing healthcare to the patient, not dragging the patient out of their house, you know, for all those reasons why you guys just talked about, but bringing it to them. That's the consumer model. I don't like to necessarily use that, but that is just what you were talking about. Well, let's see. We're at 23 minutes. Jackie, do you have a heartwarming story that you can tell us about?
Sure, absolutely. We're full of them. What immediately comes to mind is somebody that I've been dealing with and working with for months now. She's a mother of 6. We have her on telemonitoring, and this started when she went into a heart failure exacerbation. She has many comorbidities. She's morbidly obese. And she went into a heart failure exacerbation right at the beginning of the pandemic, the COVID-19 pandemic. She's preparing for bariatric surgery. And so she really was having a hard time getting her weight down, especially with her heart failure on top of things. Again, a mother of 6. And so she's got little ones running around doing virtual school, and she's trying to manage her health as well. And her doctors are trying to keep her out of the hospital because of that was in the very beginning stages of the pandemic. And so we initiated IV diuretics. We collaborated with her cardiologist. We collaborated with the infusion company and our home care nurses and telemonitoring, and we kept her out of the hospital. We were able to get her weights down. There were a couple bumps in the road along the way, as there is, but she always came back to telemonitoring. We were able to monitor her and communicate with her cardiologist, her progress, which would initiate changes in the medications. And she was diuresed through IV diuretics, made it to her goal weight, got her bariatric surgery, and she continues to drop.
That's a great story. That's a true success story and an example of it takes a village for this.
It does. It does. And she's been through a lot. And honestly, I'm going to give her a lot of the credit because she stuck with the program. She was forthcoming with us. She played her role 100%. And that's a critical piece to the puzzle.
I would say that what telemedicine has done and these types of programs is it empowers the patient.
Right. Right. She would call me before I would get a chance to call her each day. So in those beginning weeks when we were still, getting things just right for her. And she was a trooper. She worked through every little bump in the road with us. Again, she was forthcoming. She was honest. She used the equipment to her advantage. Her physicians leaned on us for feedback and updates, and otherwise they would never know. So it really is just kind of a perfect storm. Yeah.
Ashlee, do you have anything you want to add?
No, just that, it really does take a village, and it's more than just having a piece of equipment in the home and sending data over to maybe one nurse that checks it randomly. It's an entire program with a philosophy of looking at the patient and working as a team and just using all your resources and just doing everything you can and everything in your power to help the patients, navigate healthcare and just stay home safe and healthy.
Well, you guys are fantastic, and I think this is a great way to spread the word of what you're doing so people understand it and that patients, can ask for these types of services and sort of push the envelope a little bit. Mm-hmm. So we'll end it here, and thank you guys so much for joining on a Saturday, and we'll talk to you soon.
Thanks for having us.
Okay, thank you.